be talking about clinical scenarios which we encounter in trauma patients. And this is as if you are in the emergency room, you're on night call, and you're encountering these trauma patients. Now, the reason why I'm covering these scenarios is because they're repeatedly asked in the exam, especially the Central Institute exams, but even NEET asks one or two of these scenarios. So please do revise these scenarios after you've covered all the trauma modules, and definitely before your exams as well. So the first scenario is that a 28-year-old boy, a 28-year-old male comes to the emergency room after a road traffic accident, complaining of severe pain on the right side of the chest and difficulty in breathing. Okay. So there's been a road traffic accident. Again, we are going to highlight the keywords here. So there's been a road traffic accident, severe pain on the right side, difficulty in breathing. There's tachycardia, blood pressure is low, and the respiratory rate is 26 per minute. So the respiratory rate is also raised. On percussion, there is a hyper-resonant note on the right side and decreased air entry. So the last line is the giveaway, hyper-resonant note and decreased air entry. When you're percussing the right side of the chest, that means that there is air there. So that is a case of pneumothorax. Now the patient's vitals are unstable, so this becomes a case of tension pneumothorax. So this is a tension pneumothorax, where the patient has unstable vitals and there is a pneumothorax. What investigations would you do to confirm the diagnosis? So please remember a very important statement. Tension pneumothorax is a clinical diagnosis. Tension pneumothorax is a clinical diagnosis, and we don't need any investigation to confirm it. It's a clinical diagnosis. You can do investigations as adjuncts, but it is a clinical diagnosis. So please remember that. It can be an adjunct, but you don't need to necessarily perform any investigation. If you see the X-ray, you can see here that there is shifting of the mediastinum to the other side. The mediastinum is shifted to the other side, thereby compressing the other lung as well. And on this side, you see it is all black. This is pneumothorax. So there is pneumo and there's shifting of the mediastinum to the other side. Patient's vitals are unstable. This is tension pneumothorax. What is the emergency management of these patients and the definitive management? These two questions must have been asked at least 20 to 25 times in the exam. It never goes out of fashion. Always is asked in some exam each year. You should remember this. Emergency management is needle thoracocentesis. That is insertion of a wide bore needle. We have to insert a wide bore needle. Insertion of wide bore needle in the width space. So please remember this. This is an update for adults. Now it is fifth intercostal space, mid-axillary line. Right? Mid-axillary line. That is for adults. Now this is an update. For children, it is the old one only. For children, it is second intercostal space, mid-clavicular line. And if you've ever done this, you would see that there's dramatic improvement in the vitals as soon as you do this. So we've done this quite frequently when I was doing my post-graduation and senior residency. And when you put this needle, you hear a hissing sound, and you would see within a matter of seconds that the patient's vitals are improving. The definitive management is tube thoracocentesis. That is insertion of a chest tube, insertion of intercostal tube, ICT is intercostal tube, in the triangle of safety, right? I'll tell you about the triangle of safety. So that is the definitive management. These two are very important points. Another point which you should know, EFAST can be done to diagnose it, but as I've told you, it's a clinical diagnosis. It's just an adjunct. EFAST is extended fast, and when you do that, you will get seashore, barcode, or stratosphere sign. I've already told you the new update in adults is that the needle is to be inserted in the fifth intercostal space, mid-axillary line. This is the triangle of safety. The triangle of safety, the apex is formed by the axilla. Anteriorly, you have the anterior axillary fold, which is formed by the pectoralis major. Posteriorly, you have the posterior axillary fold, which is formed by the latissimus dorsi, and the fifth intercostal space forms the base. So this is where the tube has to be inserted, and we've discussed multiple times that the tube needs to be inserted along the upper border of the rib so as not to injure the neurovascular bundle which is there in the lower border. This was even asked in your INI CET exam. This is not a Eurobag. This is a chest tube underwater seal. You can see here, there's a mark here. There is a mark here. You fill it up with water till this level, and one end of the tube is submerged. Now, why is one end of the tube submerged? We've discussed this so that air can bubble out, but air doesn't get sucked inside. Air can bubble out, but it does not get sucked inside. So this is an underwater seal which is used along with chest tubes. So this was the first scenario. The second scenario, every alternate year, this is how the Central Institute exams ask them. A 36-year-old suffers a penetrating injury to the left chest post a road traffic accident. When the ambulance gets him to the ER, his GCS is 14/15. So, penetrating injury to left chest, GCS is fine. Pulse rate, there's tachycardia. BP, there is hypotension. Neck veins are distended, and there are muffled heart sounds. So again, the last line is a giveaway. Distended neck veins, muffled heart sounds, and a penetrating injury to the left side of the chest. We are dealing with a patient with cardiac tamponade. We are dealing with cardiac tamponade. Now, if you see till the third line, the features could very well have been of tension pneumothorax. The differentiators between the two are muffled heart sounds in cardiac tamponade and hyperresonant note and decreased air entry in tension pneumothorax. So those are the differentiators. Of course, it can be differentiated by EFAST as well. Now, would you like to do some investigation to confirm the diagnosis? I've again told you it is a clinical diagnosis. It is a clinical diagnosis, and the investigations are just an adjunct. EFAST can again diagnose this condition. You can see that there is a collection around the heart, and this was asked last year in the AIIMS exam. You can see that there is a collection around the heart, and they had shown a FAST scan or an EFAST scan, and they had asked you whether the EFAST scan is positive or not. So always remember, if you get this hypoechoic, this blackish collection, either in the abdomen or around the heart, that means there is fluid there or blood there. So it is a positive EFAST scan. The management of these patients, the emergency management again has been asked many times. The emergency management is needle pericardiocentesis. And this I've covered in detail. Needle pericardiocentesis. So we do needle pericardiocentesis in this case, and please remember needle pericardiocentesis, ECG or echo control, because when we do this there can be arrhythmias. And the left costoxiphoid angle, that is where a needle is inserted at a 45-degree angle to the skin, and it is directed towards the left shoulder tip. And as you keep on advancing, you keep on aspirating. And as soon as there is a loss of resistance, when you insert and there'll be a slight loss of resistance, that's when you've entered the pericardium and you can aspirate blood. Again, you would see that if 5 to 10 cc of blood is also aspirated, there is a dramatic improvement in the hemodynamic profile. So what we usually do is we put this needle, we aspirate, and then we leave the needle there for further aspiration if required, but we shift the patient for definitive management to the theater. The definitive management is we have to carry out a thoracotomy and create a pericardial window. Create pericardial window. That means basically put in a drain there, and we have to repair the injury. We have to repair the injury and just put a drain there. So if there's any residual collection, that can come out through that drain. That is the definitive management of cardiac tamponade. I've told you these two scenarios are the most important in trauma. Again, one scenario pertaining to head injury is also asked in the Central Institute exams. It was there in the INI CET exam as well. So you have a young batsman who gets hit by the ball on the head and he loses consciousness for a brief moment. So gets hit on the head with the ball, loses consciousness for a brief moment. He recovers and is being taken to the hospital when he loses consciousness again. So initial loss of consciousness, then normal, then again loss of consciousness. You know, this is lucid interval. And young patient, high velocity trauma, lucid interval, what do you suspect? You will suspect an extradural hemorrhage. EDH is what we suspect. But how do we confirm the diagnosis? You know, the investigation of choice is NCCT. For head injury, it is not CCT, it is non-contrast CT scan, please. Non-contrast CT scan. And on a non-contrast CT scan, you get a biconvex hemorrhage. You can see here a biconvex or a lens-shaped hemorrhage. This image has also been asked multiple times in the exam. Now, how do we manage this patient? So, if you're in a corporate hospital or if you're in a government hospital also where neurosurgery facilities are there, then we are going to take up this patient for a craniotomy provided the clot size is more than 30 cc. There is a more than 5 millimeter midline shift. So if you look here, if there is a midline shift of more than 5 millimeters, if there's a midline shift of more than 5 millimeters, or the thickness of the clot is more than 1.5 centimeters. If this thickness is more than 1.5 centimeters, these are the indications to carry out a craniotomy in a patient with EDH. Burr hole these days is only reserved if the facilities for craniotomy is not there, or if you don't have a CT and you are just suspecting that there is an EDH, so you make a burr hole and see if there's blood there or not. It can be both diagnostic and therapeutic in such a case if you don't have a CT scan. But otherwise, we do a craniotomy, and I've told you the indications. You also know that it is the middle meningeal artery which is the most commonly implicated vessel in extradural hemorrhage. This we've already covered. I've told you most of the points. It is the middle meningeal artery. Please remember that lucid interval is common in EDH but not exclusive to it. The other one is SDH. SDH is concavo-convex hemorrhage. This also has been covered in the modules. It is concavo-convex hemorrhage or crescentric hemorrhage which you get in SDH, and in SDH it is mainly the venous blood which is there, which is due to the bridging veins. Another clinical scenario which you should know about, this is again very important. This was the one which was asked in the INI CET exam. A 22-year-old male with road traffic accident is brought to the emergency room. His GCS is E2, M2, V2. So his GCS is 6, and you know a GCS of 8 or less than 8, the patient is probably in a state of coma, right? He has no fractures and NCCT is performed, but the NCCT is normal, but his GCS is not improving. Right, so what has happened is that comatose patient post RTA, his GCS is 6, but NCCT head is absolutely normal, but GCS is not improving. This is the classical feature, NCCT normal, but patient is in coma. This we've discussed. What do you suspect? You suspect diffuse axonal injury. What were the key words? Coma, NCCT normal, not improving. So diffuse axonal injury, you know it occurs due to shearing force between the gray and the white matter. The investigation of choice here is an MRI, and you can see that NCCT would be normal here. NCCT is normal. On MRI, you will see punctate hemorrhages at the gray and the white matter junction, and this has the worst prognosis amongst all head injuries. Diffuse axonal injury has the worst prognosis amongst all head injuries. So most severe type of primary brain injury, and I've told you MRI, worst prognosis. So the next scenario is a 24-year-old meets with a road traffic accident and is rushed to the ER. He says that he got hurt on the head. So patient is telling you that he got hurt on the head. On examination, GCS is 12/15. Okay. There is no external injury involving the head or the rest of the body. You can't see any lacerations, you can't see any active bleeding, neither on the head nor on the body. You've done a proper survey. But his pulse rate is 110, there's tachycardia. BP is 90 systolic, that means BP is also low. Patient has a feeble pulse, right? Again, because there is some hypovolemia, that is why there's feeble pulse and the JVP is low. So what is this scenario? This patient has hypovolemic shock, right? He has a feeble pulse, he has a low JVP, he has tachycardia, and he has hypotension. If you remember the module on shock, if the patient has hypotension, he is already in class 3 shock. But where is the bleeding? Because there are no signs of injury. So is it just the head injury which is leading to this? Is there a bleed in the head? Please remember this point. Okay. And this I've highlighted in the modules. I'm highlighting it again because it's very important. Isolated head bleed will not give rise to hypovolemic shock. Will not give rise to hypovolemic shock. So then what do we do in this patient? Where do we search? So always remember, if you can't see blood outside, on the floor, or if the patient is not bleeding, you need to search in the neck, you need to search in the thorax, you need to search in the abdomen and the pelvis. These are the 4 areas where blood can accumulate. Neck would again be visible with a visible swelling in the neck. But for thorax, abdomen and pelvis, we can do EFAST. You know, FAST is focus assessment sonogram in trauma. It is the scan which is done in the emergency room. Again, a pet favorite of the Central Institute exams, but a lot of time it's been asked in the NEET exam as well. So you know, FAST, the 4 positions where you keep the probe, it is epigastrium, right hypochondrium second, left hypochondrium third, and let's make this suprapubic region. Suprapubic region is where we keep it, but we are looking in the pelvis. We look for collection in the pelvis, but we keep it in the suprapubic region. And this is the order: epigastrium, right hypochondrium, left hypochondrium, suprapubic. This has been highlighted clearly in the ATLS guidelines, and that's what we are going to follow. The same order: epigastrium, right hypochondrium, left hypochondrium, suprapubic region. EFAST is extended fast, that is fast plus the thoracic cavity. So it is 4 plus 2, total 6 areas where you can keep the probe. So in this patient, if you do an EFAST, we can find out where exactly is the bleeding happening, and then we can intervene accordingly. Now this patient is diagnosed with a grade 4 splenic injury. How do we manage a grade 4 splenic injury? Patient has unstable vitals. We will rush the patient to the theater. Before that, IV fluids are to be given. IV antibiotics are to be given. Analgesics are to be given. And we rush the patient for an emergency exploratory laparotomy. Grade 4 unstable vitals, patient is going to land up with a splenectomy. So this is the management of splenic trauma. I've already covered this in great detail. Grade 4 injury, unstable patient, fast we will do, and the patient is rushed for surgery. A splenectomy is done. Now this patient has an uneventful surgery. You were with your senior resident. The senior resident removes the spleen. Everything is fine, but the patient develops fever on post-operative day 1, which is not settling, and we have done a splenectomy. So what is it? Is it opportunistic post-splenectomy infection, or is it atelectasis? Don't get confused here. This question has been asked many times. Day 1, the fever is occurring. The most likely cause is atelectasis on the left side. Atelectasis, is collapse of the alveoli. And respiratory complications are the most common complications following splenectomy. So the patient has atelectasis on the left side, which is giving rise to this fever, or a developing pneumonia on the left side. You would like to start this patient on incentive spirometry for chest physiotherapy. Now you have a 29-year-old boy. He suffers a stab injury in the abdomen. Got into a fight and somebody stabbed him. The image is shown. Vitals are stable. So you can see the image. You can see here that a tag of omentum is protruding out from the stab wound. Omentum is protruding out from the stab wound. So how do we manage this patient? Is it conservative or surgical? Well, I've told you, if there is a penetrating trauma to the abdomen, if there is a penetrating injury to the abdomen, and if the patient's vitals are unstable, which is not the case here, or there is bile staining of the dressing, not the case here. If omentum is protruding out, that means the peritoneum has been breached, or the patient has features of peritonitis. These are the 4 indications where we have to go for an emergency laparotomy in these patients. You cannot avoid a laparotomy. Conservative management in these 4 scenarios in penetrating abdominal trauma does not have a role. So these were the scenarios which I want you to know for the exam. Invariably, one of them comes in the MCQ exam. Also, it would help you during your internship when you're working in the surgical emergency. So please do revise these scenarios before the exam. All the best.